I think a lot of it is exaggerated, so don't take it at face value. I'm really honored and glad that we were able to finally organize this. As Dr. Somshekhar was mentioning, we've been planning this for a long time, but it's finally come into action, and I'm glad that I'm able to be part of this. So I'm going to be doing two things. One will be the actual overview on the management of esophageal cancer. And the second will be to critically look at two studies which Dr. Somshekhar asked me to review, which are actually landmark studies and have made a major impact on the way we treat esophageal cancer. So I'll just confirm that my slides are visible.
Yes.
Yes, great. And as Dr. Somshekhar mentioned, please feel free to record this, go back to this at any point. What I've tried to do is to make sure that this is comprehensive enough that you probably may not need to go through these aspects before your exams or even during your practice. So I've tried to make it as comprehensive as possible. And I would like this session to be interactive and a lot of back and forth. So please feel free to jot down your questions or any comments that you might have, and we'll address that towards the end of this session. So what I'll do in the first talk is to initially start with the management algorithm. We'll start with that so that we're all on the same page as far as the basics of esophageal cancer management is concerned. I'll go briefly into the epidemiology of squamous and adenocarcinoma, and there is a specific reason I will be doing that. We'll go on to the surgical issues, the various approaches, the extent of lymphadenectomy, both of which are fairly controversial and debatable issues in esophageal cancer management. But as surgeons, we cannot ignore the impact that multimodality treatment has. So it is extremely important that we are part of a multidisciplinary team when it comes to making treatment decisions for esophageal cancer. And I'll go through some of those issues. And I'll very briefly summarize ongoing and future research, and we will have a summary at the end of it. So when it comes to the management of esophageal cancer, and these are taken from the National Cancer Grid resource stratified guidelines, and I'll urge each of you to go through to the National Cancer Grid website where all of these guidelines are available free for access. It's not just with esophageal and lung cancer, it's available for all the major cancers, and it's a fairly good resource which has been put together by a whole lot of experts. So any patient with dysphagia or persistent heartburn requires an upper GI scopy. A couple of decades back, the investigation of choice used to be a barium swallow, but we have moved away from this for very specific reasons. The fact that barium swallow does not pick up very, very early disease, and in patients with confirmed disease on barium swallow, anyway, you require an upper GI scopy. So the barium swallow has now become more or less a redundant investigation as far as the diagnosis of esophageal cancer is concerned. It's also important to understand that along with the scopy, we need multiple biopsies. A minimum of 6 to 8 biopsies is what is recommended to ensure that there is no need to repeat an upper GI endoscopy merely to get a diagnosis. And once it is proven malignant, the basic investigations that are required are a contrast-enhanced CT scan of the lower neck, thorax, and abdomen. If it is a GE junction tumor, the pelvis is also included. Bronchoscopy is used very selectively, only for upper and middle third esophageal cancers or any patient with a history of change in voice. And we institute nutritional support very early into the management paradigm as we are investigating these patients, because many of them are malnourished. It is important that we use the time even that is taken for investigations to build up their nutrition. I've added some which I've put in as optional procedures. The first of which is endoscopic ultrasonography. It is clearly useful in those who are borderline operable after neoadjuvant treatment, or in patients which are early cases where you would potentially consider these patients for upfront surgery rather than neoadjuvant treatment. And the reason I say this is that if you are ever considering upfront surgery in a patient with esophageal cancer today, you need to be sure that they are either T1 or T2 and N0. And an endoscopic ultrasound gives you these details much better than any other imaging modality. In areas where it's available, a PET CT scan is a very useful investigation to do. And in our own series of over 200 patients, we've realized or we've analyzed the data, and we found that the incremental value of a PET CT scan over a contrast-enhanced CT scan is to the tune of 19% in squamous cell cancers and 29% in cases of adenocarcinoma. So wherever available, a PET CT scan is a very useful investigation. And the reason it's useful is that it picks up distant metastasis beyond what is seen in a contrast-enhanced CT of the neck, thorax, and abdomen. So this is a fairly complex slide, but I'll take you through this over the next 2 to 3 minutes. So as I mentioned, in patients which are early localized, that is T1, T2, N0, which has been confirmed on endoscopic ultrasound, we prefer upfront surgery, either by way of a transthoracic or a transhiatal esophageectomy. There is one small subset in this, which is the T1, SM1, which is an extremely early disease, where ESD or EMR are potential options, but with the caveat that the operator needs to be experienced in endoscopic treatment of these tumors at this stage. And in patients who have undergone a complete resection, there is no role for any adjuvant treatment. If it is R+ or with positive margins, which means that your actual endoscopic staging has failed, because with the T1, T2, N0, you wouldn't really expect an R+ resection, but in those very rare situations, postoperative radiotherapy may be considered. In those with T1, T2, N0, but who are unfit for surgery or for some reason refuse surgery, the next best option is definitive radical radiotherapy with or without chemo. There is fair evidence to show that definitive concurrent chemoradiation is superior to radical radiotherapy alone, and is also superior to sequential chemoradiation. So in a patient who's fit, but for some reason is refusing surgery, the next best option is definitive chemoradiation. The vast majority of our patients come in this stage, which is loco-regionally advanced, which is T3 or T4, and it is N+. So basically, if you're able to see a fairly bulky growth on CT scan, you don't even require an endoscopic ultrasound to confirm that it is T3 and not T2. Any growth which is a bulky growth on CT scan is actually a minimum of a T3. And in those who are squamous cell cancers, there are two options: neoadjuvant chemoradiation, which is either the cross or the NCCN protocols, which vary very marginally, or the neoadjuvant chemotherapy alone, which is either a platinum 5FU or a paclitaxel platinum doublet. We will be discussing this a little more in detail a little later in the talk. But in adenocarcinomas, you have the options of perioperative chemotherapy, either with FLOT, ECF, or EUX, or neoadjuvant chemoradiation. And this is followed, either of these approaches in squamous and adenocarcinomas is followed by a re-evaluation with either a PET CT scan or a contrast-enhanced CT scan. And in those with resectable disease, surgery is the treatment of choice. And if it is unresectable, chemoradiation or radiation or palliative procedures. The subset which is metastatic, which is M1 disease, the options are palliative radiation, which could be either external beam radiation or intraluminal radiation. And this is preferred because it has anti-cancer treatment as well. If the patient is not fit or has completely dysphagic, endoscopic stenting is the treatment of choice. It is also important that treatment doesn't stop with this. We also need to provide pain management and nutritional support. If it is adenocarcinoma, there is a role for chemotherapy, and it is important to know what the HER2 status is, and if it is HER2 positive, trastuzumab might be considered in patients who are otherwise suitable. In squamous cell cancers, if the patient is symptomatic and radiotherapy is not feasible, chemotherapy might be considered. The reason we put this as optional is primarily because the dysphagia relief, which is the primary aim of palliation, is quite temporary with chemotherapy. And as soon as you stop the chemotherapy, the dysphagia comes back. So it's not a great option for palliation. That is why we prefer palliative radiation. So I'll go to the first issue of what we should discuss, whether histology matters, the issue of squamous versus adenocarcinoma. And as you might well know, any chapter of esophageal cancer starts with this kind of data, which shows that esophageal adenocarcinomas have been it's been one of the most rapidly growing cancers in the West, and it has had more than a 400% increase in incidence in high-income countries. On the other hand, when you look at Eastern countries like Japan or India, it has been more or less a straight line. There has been marginal variations in the incidence of squamous cancers, which far outnumber the incidence of adenocarcinomas. And currently what we see in India is roughly an 80-20 split. The risk factors for squamous and adenocarcinomas are also very different. Squamous cancers are more related to tobacco and alcohol use, whereas adenocarcinomas are more related to reflux and Barrett's esophagus. Uh, and prognosis-wise also, it is very different. Adenocarcinomas are more likely to present with metastatic disease, but the overall median survival for adenocarcinomas is better than squamous cell cancers. And there is no difference. Once it is metastatic, there is no difference in outcomes between squamous and adenocarcinomas. Perioperative outcomes are also fairly different. The perioperative mortality with squamous cell cancers is higher than with adenocarcinomas. Respiratory complications are more or less similar. However, arrhythmias are more common with squamous cell carcinomas, and this is probably to do with the fact that you're handling the mediastinum a lot more when you're operating a patient with a squamous cell carcinoma rather than any inherent histological difference causing these complications. Again, anastomotic leaks as well as chylothorax are more common with squamous cell cancer. So practically, and when you look at survival as well, they are fairly different. So we do realize that squamous and adenocarcinomas have different etiology, they have different presentation, they have different prognosis. But unfortunately, till very recently, most of the research as well as the management guidelines have remained the same. So this is an important point that I want you to understand. And any future research that we design should have different strata for squamous and adenocarcinomas. So we'll move on to the surgical issues. And the first one I'll look at is the surgical approach, and the other one would be extent of lymphadenectomy. I will not go into the operative technique or the perioperative complications. That's a topic for another talk. But when it comes to this, which is a very controversial and hotly debated topic as to which is the better approach, a transthoracic or a transhiatal esophageectomy, there have been two large meta-analyses which have been performed on this. But you should understand that though meta-analysis are really considered, traditionally considered to be high level of evidence, it depends on the studies which constitute the meta-analysis. And here this is a very good example of how this is true. And though the meta-analysis had 50 trials in all, only 3 of them were randomized trials and only 6 of them were prospective. So the vast majority were either retrospective comparative trials or separate isolated series of TTE or a transhiatal esophageectomy. So clearly the quality of the meta-analysis is not great. Nevertheless, what we have from this is the fact that virtually there are, overall, if you look at the complications, the anastomotic leaks, the vocal cord palsy, there doesn't seem to be a very big difference between a transthoracic and a transhiatal approach as when you look at the overall data. But what I'll point out to the fact is that while the cardiac and the pulmonary complications, while the cardiac complications seem to be much higher with a transhiatal, probably because of the partly blind mobilization of the intrathoracic esophagus, the pulmonary complications seem to be higher with the transthoracic esophageectomy. But this is as far as all the 50 trials are concerned. And again, similarly, anastomotic leaks seem to be higher with a transhiatal. But again, this is a reflection of the fact that many of the transthoracic were actually Ivor Lewis and not a 3-stage McEwen. The leak rates are lower with a Ivor Lewis than with the McEwens, primarily because the stomach needs to traverse a shorter distance and therefore is more vascular at the site of the anastomosis. When you look at vocal cord palsy, a transhiatal again has a higher incidence, probably because the anastomosis in the neck and during mobilization of the esophagus in the neck, you might injure the left recurrent nerve. Whereas in a Ivor Lewis, again, because you don't go in the region of the left recurrent, you don't end up damaging the nerve. But what I would want you to look at more carefully is the randomized evidence. Though there are only 3 randomized trials, if you look at the randomized evidence alone, there doesn't seem to be much difference, and it is actually sometimes even higher in a transhiatal with the pulmonary complications as compared to the transthoracic esophageectomy. So this meta-analysis is not actually a great meta-analysis, primarily because the studies constituting it have not been good studies. This was again published a little later. This is a more recent meta-analysis, which again looked at similar studies and came to a fairly similar conclusion. But the largest study that we currently have is the Dutch randomized trial, which randomized patients with esophageal and GE junction tumors to either a transthoracic esophageectomy or a transhiatal esophageectomy. The original publication showed a 10% difference in overall survival, which, however, didn't reach statistical significance because the number of patients were low. It only had 220 patients overall in the study, just over 100 patients in each arm. But it showed a 10% difference in overall survival between a transthoracic and a transhiatal, favoring the transthoracic group. There was an updated meta-analysis of the Dutch randomized trial, more long-term results, and this showed no difference in 5-year survival. So 36% versus 34%. But when you look at the subsets of esophageal versus junctional or the G junction tumors, in esophageal cancers, when you did a transthoracic approach, there was a 14% improvement in survival with the transthoracic approach as compared to the transhiatal approach. 51% survival in transthoracic compared to 37% with the transhiatal. And the authors actually concluded by recommending a transthoracic approach for esophageal cancers and a transhiatal approach for junctional and cardiac cancers. The next approach that has come in, which has made the previous debate more or less redundant, is the minimally invasive esophagectomy. Nothing has transformed the way we operate on esophageal cancers as much as thoracoscopic or robotic esophagectomy is concerned. We've had remarkable advances in optics and equipment, which make a minimal invasive esophagectomy true advance in surgery. There is less invasive surgery and there is no compromise on radicality. There is enough data to support that. The initial fears of oncological safety have been to a large extent addressed because radicality of surgery as well as port site metastasis are more theoretical than in practice. And we've got several reports with surrogate oncological safety variables like the R0 resection rate as well as the lymph nodal yield, which show that at the very least, minimal invasive esophagectomy is at least as good as an open esophagectomy. There have been multiple meta-analyses which have looked at this approach again, but again, most of these are retrospective or prospective non-randomized trials, again, going with the quality caveat that I mentioned earlier on. And the overall complication rates in these studies have favored a minimal invasive approach, along with the pulmonary complications, which clearly show a benefit with the minimal invasive approach, as well as all other complications that are related to surgery. We've got two large randomized, not large, fairly well-conducted randomized trials. The TIME trial, which was the first one to be published, which clearly showed that the primary outcome that they were looking at, which was pulmonary infection within 2 weeks, was significantly superior with a minimal invasive esophagectomy, just 9% as compared to 29% with an open esophagectomy. And even in-hospital pulmonary infection rates were 12% versus 34%. And though there was a small difference in the hospital stay, 11 days versus 14 days, most of the other aspects like the short-term quality of life and the resection rates were fairly similar between these two approaches. The TIME trial looked at DFS and OS as well, and there was no significant difference, but this was not powered to look at differences in overall or disease-free survival, so we need to take this with a pinch of salt. But at least it does not seem to be dramatically lower than an open esophagectomy, and we don't really expect a minimal invasive esophagectomy to be a oncologically superior surgery. However, the MIRO trial showed slightly different results compared to the TIME trial. This is a hybrid esophagectomy compared to an open approach. And what the MIRO trial showed was that the major complication rates were significantly lower with a minimal invasive esophagectomy, which is just 36% compared to 64% with an open esophagectomy. And the postoperative mortality and at 30 days and 90 days were not too different. The major pulmonary complications were 18% with the hybrid approach and 30% with the open approach. But what was an unexpected finding of the MIRO trial was this data, which showed that the hybrid minimal invasive esophagectomy actually had a superior survival, oncological survival, as compared to an open esophagectomy. To be honest, I think this is a chance finding. I don't see a reason why a hybrid minimal invasive esophagectomy could be superior oncologically than a well-done open esophagectomy. This was true even for both disease-free survival as well as for overall survival, which is again quite surprising. So let's see what happens in the real world. What we've looked at is a couple of randomized trials in high-volume expert centers. But what happens in the real world is slightly different. This is really nice study which came out of Japan, which was a propensity-based approach to comparing open with minimal invasive esophagectomy. This was a real-world data from 860 plus hospitals in Japan. They were propensity score matched for all other risk factors, close to 3,500 patients in the open arm and the similar number in the minimal invasive esophagectomy arm. The open surgery took significantly lower time, approximately an hour lower than the minimal invasive approach. Blood loss was again significantly lower, approximately two-thirds of the blood loss of an open hysterectomy is what was seen in a minimal hysterectomy, and that has been our experience as well. But surprisingly, in the real world, and this is in a country like Japan, where thoracoscopic surgery cannot be performed by esophageal surgeons unless they're accredited to do so after sending their videos for quality by an expert group of esophageal thoracoscopic surgeons. And in this elite group of thoracoscopic surgeons, what was disappointing to see was that in morbidity, with atelectasis, with prolonged ventilation, with pneumonia, with mortality, as well as operative mortality, there didn't seem to be a big difference in outcomes between the open and the minimal invasive approach. This did come as a bit of a surprise, especially considering the fact that both open and thoracoscopic surgeons in Japan are probably amongst the best in the world. Going on to perioperative outcomes as well, again with surgical site infection, the recurrent adenocarcinoma palsy, the reoperation rate, as well as anastomotic rates were fairly similar. I'll just point you out to the slight blip that you see here, a slightly higher incidence of gastric tube necrosis, though it didn't reach statistical significance. I just want you to remember this as we come to a subsequent study where this will become even more clear. Japan is actually currently conducting a randomized trial, which is a non-inferiority trial looking at overall survival, and accrual is going on with a sample size of 300 patients. And we expect that this will be the largest trial looking at survival as an outcome in this debate between an open and a minimal invasive approach. There's another study which has come out of Netherlands, which is again looking at real-world data comparing an open versus minimally invasive transthoracic hysterectomy. And again, Netherlands is a country where the quality of surgery is extremely stringently monitored. They are done only in a few high-volume experience centers. The perioperative care is extremely good. And again, when you look at it, the overall morbidity, the pulmonary complications, anastomotic leak rates seem to be fairly similar. In fact, if at all, there is a slightly higher anastomotic rate, which actually reached statistical significance. But let's look at this interesting finding, which I pointed out even in the Japanese study, the one about gastric conduit necrosis. It seems to be substantially higher, whereas it's only 0.2% with an open hysterectomy. It's almost 3.2% with a minimal invasive hysterectomy, reaching statistical significance. Now, there are various theories as to why this has happened. Is this because of the higher use of energy devices and the fear of injuring some of the short gastric vessels, which is making the surgeon go close to the gastric wall when they are ligating or dividing these short gastric vessels? Is it because of increased handling of the stomach tube in minimal invasive hysterectomy, a harsher instrument handling the stomach as compared to our hands during open hysterectomy? There are many theories to do that, but this is something that is seen consistently across quite a few studies, and something that we need to be very careful about when we perform our own minimal invasive hysterectomies. And again, when it comes to reintervention, recurrent palsy, and mortality, there doesn't seem to be that much of a difference between an open and a minimal invasive hysterectomy, so long as the real-world data is concerned. So the take-home messages that I will leave you with is that in ideal circumstances, minimal invasive hysterectomy is the ideal approach to operable esophageal cancer, because we now have level 1 evidence to show that the perioperative outcomes, the complication rates is much lower with minimal invasive hysterectomy. However, this reduced morbidity comes with equivalent oncological outcomes. But I must leave this with a caveat that this needs to be done in experienced centers by experienced surgeons. However, when it's rolled out into the community, the differences narrow down, and the advantage that is seen with an MIE seems to be much lower when it's out in the real world. We'll go on to the next controversy, which is on the role of lymphadenectomy. This is a long-standing controversy. There are two schools of thought. One which says that lymph nodes are just indicators and they do not improve survival even if you remove them. Whereas the other thought is that not only improves survival, not only improves staging, but it also improves locoregional control and survival. And for those of you who are inclined to reading some of the best papers that have come out on this topic, I'll go back to almost 25 years back. These are genuinely landmark papers which have come out of Japan. One of the largest centers which used to treat esophageal cancer, Professor Akiyama, is a legend in esophageal surgery. And this was published with his then protege, Surumaru, from the Toranomon Hospital, which was a very high volume, continues to be a high volume esophageal cancer unit. And what they showed was that the cervical lymph node involvement, their study as well as several other studies, showed that cervical cancer lymph node involvement was anywhere from 27% to 43%, depending on which series you went through. And this was unsuspected at the beginning of the surgery itself. And again, a really good article written by Akiyama and his student, who's now the head of esophageal surgery in one of the other centers in Tokyo, Udagawa, where they actually went through every single lymph node station. This is truly a wonderful paper to go through, hand-drawn images of the esophagus, the lymph node stations, and they clearly showed that cervical lymph node involvement, especially with upper and middle and even with lower esophageal cancers, was in the range of 27 to 46%. And therefore, there was a strong rationale for doing a lymphadenectomy. The original paper from Akiyama showed almost a 12% difference in 3-year survival and a 16% difference in survival with a 3-field lymphadenectomy as compared to a 2-field lymphadenectomy. The 1994 consensus conference of the ISD actually said that there are 3 issues that needed to be addressed. While there is certainly benefit in improved staging with treatment planning, probably the prevention of local recurrence, and in some subgroups, better long-term survival, the unaddressed questions or the unanswered questions were on surgical morbidity and mortality, local regional control and survival, and urged that well-conducted randomized trials needed to be done. I'm talking of something 27 years back, and I'll come to what has happened in the subsequent 27 years. So far, there have just been 2 randomized studies. Both of them have a number of flaws. The Kato trial had just 150 patients. The Nishihara study was an even smaller study, which is just over 60 patients. And however, what this showed was that with a 3-field lymphadenectomy, you had anywhere from a 15 to an 18% improvement in overall survival with a 3-field lymphadenectomy as compared to a 2-field lymphadenectomy. This didn't reach statistical significance with the Nishihara study because the number of patients was just over 60. But it did give a hint that the survival might be better with a 3-field lymphadenectomy, but did not answer this question conclusively. There's another extremely good study done coming out of Japan. Some of the seminal studies done in esophageal cancer come out of Japan, and I'll urge you to go through some of their studies, the recent JCOG studies, very carefully, because they have transformed the way we treat esophageal cancer, at least in this part of the world. So this study compared over 4,600 patients who underwent either a 3-field or a 2-field lymphadenectomy in 96 institutions. And what it showed was that operative mortality was fairly similar between a 2-field and a 3-field lymphadenectomy. Recurrent laryngeal nerve palsy, as you might expect, is higher with a 3-field lymphadenectomy. Lymph node metastasis were picked up more with a 3-field lymphadenectomy. And in spite of that, you had a 7% overall improvement in survival. So what you're seeing here is, even in the real world, there does seem to be an improvement in outcomes with the 3-field lymphadenectomy. At the Tata Memorial Center, we have just concluded the world's largest randomized trial on radical lymphadenectomy, where we randomized 700 patients, equal numbers, which underwent 2-field and 3-field, with a primary endpoint of overall survival. We completed recruitment of the 700 patients a year and a half back, and we're waiting for the survival results to mature before we publish the results of this study. We'll move on to the next controversy, which is multimodality treatment of esophageal cancer. The first study which came out on this is this intergroup trial, which looked at neoadjuvant chemotherapy. This was an American trial which got published in the late 90s, which showed no difference with neoadjuvant chemotherapy compared to surgery alone. But the MRC trial, which came out in the early 2000s, had a contrary conclusion. Both with disease-free survival as well as overall survival, the neoadjuvant chemotherapy protocol had a 5% improvement in survival. Similarly, there were studies done on neoadjuvant chemoradiation. Again, the first few studies were negative. This was the largest study done at that time, which was the Pramesh study coming out of Australia, which showed that there was no difference in outcomes between chemoradiation followed by surgery to surgery alone. But you now have the landmark trial. We'll go into this trial a little more in detail in the second talk, where this showed a conclusive improvement in survival when neoadjuvant chemoradiation was offered, followed by surgery, as compared to surgery alone. Very rarely will you see this kind of separation of curves with any intervention in oncology. And the long-term results of this also showed improvement in, confirmed the improvement in overall survival. There have been quite a few meta-analyses, but the best known amongst them is the meta-analysis that have come out of the Australasian gastrointestinal trials group, which showed that when you compared neoadjuvant chemotherapy alone to surgery, neoadjuvant chemotherapy followed by surgery to surgery alone, it showed a statistically significant improvement in outcomes favoring neoadjuvant chemotherapy followed by surgery. Very similarly, when you compare the trials comparing neoadjuvant chemoradiotherapy to followed by surgery to surgery alone, this also showed an improvement in overall survival as compared to surgery alone. Unfortunately, we don't have enough studies which compare neoadjuvant chemotherapy to chemoradiation. But when you looked at the mortality in the meta-analysis of neoadjuvant chemotherapy followed by surgery with chemoradiation followed by surgery, what you see is that with neoadjuvant chemotherapy, there is virtually no difference in outcomes as far as perioperative outcomes, as far as perioperative mortality is concerned. Whereas with neoadjuvant chemoradiation, there is a hint towards an increased perioperative mortality when you offer neoadjuvant chemoradiation as compared to surgery alone. And even in the 2011 Australasian meta-analysis, what you can see here is that the post-operative mortality was significantly higher, 2.1 times higher with neoadjuvant chemoradiation followed by surgery, whereas the post-operative mortality with neoadjuvant chemo followed by surgery was identical, which seems to hint that the improved outcomes that you get with neoadjuvant chemoradiation does come at a cost of a slightly higher perioperative mortality. We have some of the more recent trials after the meta-analysis was published. This was the MRC OEO5 trial, which looked at close to 900 patients getting randomized to 2 different forms of chemotherapy. The standard arm was the 2 cycles of cisplatin 5-FU followed by surgery, and the experimental arm was 4 cycles of ECX followed by surgery. The R0 resection rates as well as the postoperative complications were very similar. However, there was increased toxicity with more chemotherapy being given as compared to less chemotherapy being given. And disappointingly, the 3-year survival was no different between the 2 arms. So it is not always true that more chemotherapy is better than less chemotherapy. This is a very good example that stopping at 2 cycles of platinum-based chemotherapy is as good as giving more cycles. In fact, superior because it comes at a lower toxicity. We have the FLOT4 study, which is again a remarkable study in the way they looked at perioperative chemotherapy outcomes for esophageal and junctional adenocarcinomas. This is again one of the few studies which have separated squamous from adenocarcinomas, which I said is very important. And what they did was randomize 700 odd patients to either the existing standard of care, which was the ECF or the ECX, which was the MAGIC protocol, with the FLOT protocol, which was a slightly more intensive chemotherapy that was given. And what you saw was a clearly superior survival being seen with the FLOT as compared to the MAGIC protocol, both with disease-free as well as with overall survival. And it's important, I'll bring you back to this table a little later in the second talk. What you're seeing here is a significant 12-month difference in progression-free survival, 18 months versus 30 months, superior outcomes with FLOT, and even with overall survival, a 15-month superior survival with FLOT as compared to ECX or ECF. So these are the kind of outcomes that you see with FLOT. And I think currently, at least, with perioperative chemo being the standard of care for junctional adenocarcinomas, FLOT seems to be the ideal chemotherapy regime. These are some of the more recent studies which have come in, which have compared neoadjuvant chemotherapy with chemoradiation. This was a phase 2 randomized trial looking at complete response as the primary outcome. And as you might expect, the complete response rates was statistically superior, significantly superior with neoadjuvant chemoradiation, 28% complete response versus 9% complete response with just chemotherapy. R0 resections were also superior with 87% versus 74% with just chemotherapy, 87% with chemoradiation. With all of this, you might expect that the survival would be superior. But again, disappointingly, what this showed was that there was virtually no difference in survival when it came to comparing neoadjuvant chemoradiation as compared to chemotherapy. So though there were higher complete response rates, higher R0 resections, overall survival was no different between the chemoradiation and the chemotherapy groups. But when they did a subset analysis, what you see here is very interesting. The 3-year survival with adenocarcinomas was actually slightly worse with chemoradiation as compared to chemotherapy, though this was not statistically significant. However, with squamous cell cancers, there seemed to be a hint towards improved outcomes with chemoradiation as compared to chemotherapy. So again, demonstrating that squamous and adenocarcinomas are completely different diseases and we need to treat them very differently. The NEO-AG's study is also looking at a cross protocol compared to either a MAGIC, which was in the initial part, and later on in the FLOT protocol. 362 evaluable patients at 60% of the planned events. This was an interim analysis. There was 143 deaths, and again, disappointingly, no difference in outcomes between the cross protocol and the MAGIC FLOT protocol. And the 3-year estimated survival was virtually the same, 56% and 57%. Again, going on to show that in the kind of subsets that they are looking at in the West, which is predominantly adenocarcinomas, the role of neoadjuvant chemoradiation and the superiority of chemoradiation over chemotherapy seems to be very, very questionable. There are more trials which are addressing the same question. The Esophagus is comparing the cross versus the FLOT protocol. The top tier is comparing, again, the MAGIC protocol versus the chemoradiation protocol. And here you have a third arm of whether just a perioperative ECF is enough as compared to neoadjuvant chemoradiation. And I think with the result of all of these studies, we'll have better answers about whether chemoradiation is truly superior to chemotherapy or whether they are equivalent, at least in adenocarcinomas. So the final answer is still not available. The US and Europe either look at neoadjuvant chemoradiation, or increasingly in Europe, they look at the MAGIC versus the FLOT protocols. In East, it is again predominantly neoadjuvant chemotherapy, with the standard of care in countries like Japan and Korea still remaining chemotherapy and not neoadjuvant chemoradiation. We should admit that there is compelling evidence favoring chemoradiation from the cross trial. However, it does come at a cost of a higher perioperative morbidity and mortality. There is increasing evidence on checkpoint inhibitors and immunotherapy, one of which we'll be discussing as the landmark paper subsequently. So if you were to ask what are the ongoing and future studies that are coming, which will partially address some of these questions, one of the studies that I'm very eagerly looking forward to is this JCOG 1109 study, which is again from the Japanese group, an extremely well thought through study, which is a 3-arm study comparing a 2-drug chemotherapy compared to a 3-drug chemotherapy, that is DCF, versus chemoradiation as a preoperative therapy for locally advanced esophageal cancer. Accrual is complete on this study, and the results are expected sometime next year. And I'm hopeful that this will address this very important question in squamous subgroup as to whether chemoradiation is truly superior to either a 2 or a 3-drug chemotherapy regime. We are currently conducting the AD-aspirin trial in collaboration with the Medical Research Council of the UK. This is looking at 4 common cancers, which where we are evaluating whether adjuvant aspirin can improve outcomes over current standard of care. And this is being done in 4 cohorts: breast, colorectal, gastroesophageal, and prostate. The gastroesophageal cohort aims at recruiting 1,200 patients. We are contributing more than 50% of the patients to this overall study, which is otherwise being done in the UK and in Ireland. And this is randomizing patients to either 100 milligram aspirin for 5 years, adjuvant after surgery, or 300 milligram aspirin for 5 years after surgery, or a placebo. And the results of this will give us the answer as to whether adjuvant aspirin will improve outcomes. And there is fair degree of observational data which seems to support this hypothesis. Another study that I'm eagerly looking forward to is the SAMO trial, surgery as needed for esophageal cancer. This is based on the fact that in the cross trial, when they looked at squamous cell cancers, the response rates to neoadjuvant chemoradiation itself was in the range of 49%. And the question that they are trying to answer is that in those patients who have complete response after neoadjuvant chemoradiation, is surgery required at all? So this is a non-inferiority trial, it's a complicated step-wedge cluster randomized trial, which I won't go into the details of. But what it does is those who have a complete response after neoadjuvant chemoradiation get randomized to either active surveillance, and active surveillance is really intensive with 3-monthly endoscopies and PET scans being done. And if there are with targeted biopsies, and if there are no evidence of a residual or a recurrent disease, they go on to continue with surveillance, whereas the standard arm goes on for esophagectomy. We are also part of the NEEDS trial, which is a collaboration between the groups in Sweden, Denmark, our group in India, and potentially Japan, which is a phase 3 non-inferiority randomized trial in squamous cell cancers alone, answering the question as to whether definitive chemoradiation could be equivalent to neoadjuvant chemoradiation followed by surgery as per the cross protocol followed by surgery. This is a multicentric, multinational collaborative study of which we are also part of. In spite of all of these studies, there are still several unresolved issues in esophageal cancer. I've just listed some of these out. Is neoadjuvant chemotherapy or chemoradiation the ideal neoadjuvant treatment? And can we innovate on some of these neoadjuvant strategies? Could definitive chemoradiation be an alternative to surgery in squamous cell cancers? Will neoadjuvant immunotherapy change outcomes? There's some data to support that. Is radical lymphadenectomy likely to improve survival? And is there a role for postoperative treatment like radiotherapy in high-risk subjects, immunotherapy, and drugs like aspirin? And I'm happy to say that most of these unresolved issues are likely to get answered by well-conducted randomized trials in the next 2 to 3 years. So in summary, there is a strong evidence, the evidence base for management of esophageal cancers has improved substantially over the last 2 decades. All the randomized trials that I showed you have been done in the last 2 decades. Multi-modality treatment we know is key and is important for improving outcomes. The minimal invasive and the transthoracic approaches are probably superior to the open approach and the transhiatal approach. Lymphadenectomy does seem to matter. And however, there are still several unanswered questions which remain. And hopefully the studies that are currently ongoing will answer those questions more reliably. So that's my last slide. And I will stop with this session, with this presentation for now. And Dr. Somshekhar, how do we take this? Do we take the questions now, or do we do it after the 2 landmark trials are discussed?
I think at the end of it, we'll have it at the end of it.
Okay, great. So I'll go on to the next part of the session, which is to do with the 2 landmark trials, which I briefly addressed as part of the overall overview. But let me go a little bit more into depth of this, because critical appraisal of studies is important. Let me get the right... And what I'll also be showing you is some part of how you critically look at papers. So I'll review 2 trials. The first is the cross trial, which we briefly discussed earlier on. This was first published in 2012 in the New England Journal, because one of the landmark trials at that time. And the research question that they were trying to answer was, does neoadjuvant chemoradiation followed by surgery improve survival over surgery alone in resectable esophageal and G-junction cancers? So this was a phase 3 randomized trial, and primary endpoint was overall survival. Patients were included were both squamous and adenocarcinomas. Knowledge at that time was the fact that esophageal cancers were all similar, so they did not divide them, though they did stratify them based on histology. They included T2 or T3 tumors, so clearly resectable tumors, or if it was T1, it had to be N1 disease, and all of them were obviously non-metastatic. 18 to 75 years, WHO performance score of 0 to 2, adequate organ function, and less than 10% weight loss. The pre-treatment of workup was fairly standard. Upper GI endoscopy, endoscopic ultrasound, CCT, PET scan was not widely available at the time that study was done. It added an ultrasound neck, and if there were suspicious nodes in the neck, an FNAC was done, and a routine test for fitness. These were some of the intervention group treatment details. Chemotherapy was given weekly with a combination of paclitaxel at 50 milligram per meter square and carboplatin at AUC 2. They're given weekly on day 1, 8, 15, 22, and 29. Radiotherapy was a very gentle form of radiotherapy, which did not have much of pulmonary complications. This is important. 41.4 gray, 1.8 gray per fraction, 23 fractions starting on day 1, 5 days a week, going on for 5 weeks. And surgery was predominantly a transthoracic esophageectomy with a 2-field lymphadenectomy for esophageal cancers. The option of transhiatal for G-junction cancers was open. And in those patients who were operated after neoadjuvant chemoradiation, it was recommended that they be operated 4 to 6 weeks after completion of chemoradiation. Follow-up is every 3 months for the first year, every 6 months for the second year, and year 3 to 5 was annual. And there were no routine investigations done on follow-up. They were done only when there were symptoms of a recurrence or if there were obvious recurrences that are seen. 175 patients were needed per arm, and the assumption on which this sample size was calculated was the fact that at that time they felt that overall survival in patients who were only undergoing surgery was 16 months, and they expected a 6-month improvement in survival with the addition of neoadjuvant chemoradiation. These patients were stratified for histology, nodal status, the center in which the patient was treated, and the WHO performance status. So this is a consort diagram which shows the how the patients were recruited. Over 800 patients were assessed, out of which 370 underwent randomization, equal number in the chemoradiation and the surgery alone arm. And finally, 178 were included in the analysis in the chemoradiation followed by surgery, and 188 in the surgery alone arm. So this is a table which is standard in all randomized trials. Table 1 shows you that the demographic and the disease-related characteristics of patients in the two arms, as you might expect in any randomized trial, are very well matched. So practically similar and a similar kind of disease and patient characteristics. I must point you out to the fact that adenocarcinomas were the vast majority, 75% of them, and 23% were squamous cell cancers. Adverse events were fairly well manageable. It was the pulmonary complications were similar in the two groups. This is perioperative complications. These are postoperative complications in the two arms. Cardiac complications, chylothorax, mediastinitis, leaks, all of them were fairly similar between the two groups. Postoperative mortality was also similar in the two groups. Related to neoadjuvant chemoradiation alone, in that arm, majority of the symptoms were related to the chemoradiation part of it, which was either fatigue or nausea and leukopenia, as you might expect, and thrombocytopenia. But most of these were manageable, and they did not really contribute much to the postoperative morbidity or mortality. So when it came to the more severe adverse events, which is more than grade 3, the incidence of these complications or adverse events were fairly low. When it came to pathology, as you might expect, the R0 resection rate with surgery was 69%, that is negative circumferential, proximal, and distal margin, whereas with chemoradiation followed by surgery, it was substantially higher at 92%. Complete response rates in those who underwent neoadjuvant chemoradiation was 29%. It was 23% in adenocarcinomas, and a substantial number, 49%, almost 1 in 2 patients of squamous cell cancers had a complete response. But you must notice that this was a very small subset of the entire cohort, just 37 patients, out of which half of them had a complete response. The lymph nodal yield were fairly similar, slightly higher in the surgery group. Then this is something that we've noticed repeatedly. In patients whom we operate after neoadjuvant chemoradiation, the lymph nodal yield is slightly lower, probably because many of these nodes have been either sterilized or been eradicated by the chemoradiation part of it. Positive lymph nodes were, as expected, seen much more with the surgery alone arm. 75% of them had positive nodes as compared to just 31% in the neoadjuvant chemoradiation arm. And what it showed was a remarkably different survival with neoadjuvant chemoradiation followed by surgery. The median overall survival was 24 months with surgery alone and 49 months with neoadjuvant chemoradiation. So almost a doubling of survival with this approach of neoadjuvant chemoradiation followed by surgery. What was interesting was the subset analysis that they did. When they looked at squamous cell cancers alone, which admittedly, as you saw, is a very small number, there was a huge difference. So the top curve that you see is neoadjuvant chemoradiation followed by surgery, and the bottom curve is the surgery alone arm for squamous cell cancers. So the difference was highest in survival when you were comparing squamous cell cancers. And though these are the curves in the middle are the ones which are the adenocarcinomas, though you saw a difference, the difference was less with adenocarcinomas. And this is something that's been a recurrent theme across many studies. We had a subsequent follow-up updated analysis from the cross trial. In fact, we had 2 updated analyses. This was the intermediate one, the second publication, which seemed to indicate that the survival difference was maintained. Exactly the same survival difference that was seen in the previous, the initial paper, and doubling of survival with neoadjuvant chemoradiation. And again, similar outcomes with squamous benefiting much more than adenocarcinomas. Median overall survival in squamous was 27 with surgery versus 43 in neoadjuvant chemoradiation. But look at this median overall survival with neoadjuvant chemoradiation with squamous. At no point in our lifetimes did we think that we would have a overall median survival of 81 months, which is upwards, so it's close to 7 years median survival with squamous esophageal cancer being treated. And this is unprecedented in esophageal cancer treatment. The 10-year outcome was also reported. And what this showed was, again, that even at 10 years, there was a 13% improved survival with neoadjuvant chemoradiation as compared to surgery alone. But again, let me point this out to you. 10-year survival with surgery alone today is 25%, something which was unheard of a couple of decades back. And when you added chemoradiation to it, close to 40% of patients were alive at the end of 10 years. Again, remarkable progress that has been made in this. And again, similar to the previous study showing a much improved survival with squamous cancers as compared to adenocarcinomas. And what you see here is that if you give neoadjuvant chemoradiation followed by surgery in squamous cancers, you get almost half the patients being alive at 10 years. So 50% survival at 10 years with squamous esophageal cancer was something that was unthinkable a couple of decades back. We'll move on to the last part of my talk, which is on the second landmark paper with Dr. Somshekhar asked me to evaluate, which was the adjuvant nivolumab in resected esophageal or gastroesophageal junction cancers, which was published very recently in the New England Journal. So the research question that they were answering was, in patients who had completely resected esophageal and gastroesophageal junction after neoadjuvant chemoradiation, but had residual disease in the pathology, that is YP, T or N had to be positive, does adjuvant immunotherapy by way of checkpoint inhibitors improve survival? This was a phase 3 placebo-controlled randomized trial, a 2:1 randomization. So for every 2 patients randomized to the intervention arm, 1 patient was randomized to the control arm. And the co-primary endpoints, as they started off the trial, was overall survival as well as disease-free survival. I want you to pay attention to this because this changed during the course of the trial. The eligibility criteria was squamous or adenocarcinomas, R0 resection after neoadjuvant chemoradiation, 18 to 75 years, ECOG good, 0 to 1, and not including 2 as was in the cross trial. There had to be residual disease on the pathological report, and surgery had to be performed within 4 to 16 weeks prior to the randomization. The chemotherapy that was done was adjuvant nivolumab, started at 240 milligram every 2 weeks for 16 weeks, and 400 followed by 480 milligram every 4 weeks. And the overall treatment had to be 1 year or less. Due to enrollment challenges that they faced during the study itself, they converted the primary endpoint from the composite endpoint of overall and disease-free survival, and they converted it to only disease-free survival. So this is an important change that they've made, and the importance of disease-free survival will come later on in my talk. On follow-up, they were evaluated with either a CECT or an MRI every 12 weeks in the first 2 years. And subsequent to the 2 years, that is 3 to 5 years, it was done every 6 to 12 months. The sample size was 794 patients, 532 in the adjuvant immunotherapy arm and 262 in the no adjuvant arm. At the end of 440 events, which were either recurrence or death, the study would have adequate power to make out a survival difference. And the stratification factors were, in addition to histology and nodal status, also the PD-L1 expression, which, as all of us know, is an important prognostic factor for immunotherapy. Very similar demographic and clinical characteristics as expected. Adverse events overall were not very different between the two groups, and some of those which were related to immunotherapy were higher, as you might expect, in the immunotherapy arm. And what this showed in the primary endpoint of disease-free survival was a statistically significant improvement in outcomes with nivolumab compared to placebo. But I want you to pay some attention to the median disease-free survival. The nivolumab median disease-free survival was 22 months compared to placebo, which is 11 months. Again, a doubling of survival similar to the cross trial, but with slightly different actual duration of survival. And again, when it came to comparing squamous versus adenos, a consistent theme that was seen was that squamous seemed to benefit more from the adeno. The top and the bottom are the squamous with and without nivolumab. The middle two curves are the adenos, again, with and without nivolumab. The benefit was higher with squamous cell cancers as compared to adenocarcinomas. When it comes to disease-free survival, this is a graph, again, which the same graph which I showed you in the earlier slide as well. What I want you to focus on is this 22.4 months versus the 11 months. Now, it is incorrect to compare across trials, but I will do that just to show a fallacy of this particular trial. When you looked at the FLOT trial, the progression-free survival, which is exactly the same as what the disease-free survival in this trial was, the progression-free survival with even just chemotherapy followed by surgery, perioperative chemotherapy followed by surgery with the older regime was 18 months, and perioperative chemotherapy with surgery in the FLOT regime was 30 months. 30 months of progression-free survival with float alone. And whereas here you see patients who are treated with neoadjuvant chemoradiation followed by surgery plus adjuvant immunotherapy having a median disease-free survival of 22 months. So as I said earlier, it is incorrect to compare across trials, but I wonder whether the control arm of such a low disease-free survival of 11 months was a consequence of either poor surgery, poor perioperative management, or poor neoadjuvant therapy. Considering that most of the modern trials have shown disease-free survivals in excess of 20 months, this disease-free survival of 11 months seems fairly poor, which questions whether nivolumab is actually adding anything substantial and whether this could be, in fact, as good as it is claimed to be. So I must end with a summary that the cross trial very conclusively shows that neoadjuvant chemoradiation is superior to surgery alone for resectable esophageal and G-junction tumors. However, the Checkmate trial, though it shows statistically that the adjuvant nivolumab is probably superior in patients with residual disease after complete resection after chemoradiation, I'm not completely convinced that it gives us adequate value for the toxicity that it provides, and importantly in countries like India, for the cost that it involves. Nivolumab is not a cheap drug, and continuing it for close to a year does come at substantial cost. So I think I've come to the end of what I wanted to speak about, and I'm very happy to take any questions or comments if there are any.
Thank you very much, Pramesh. It's a beautiful encyclopedia. You know, I need to make a PDF of this file. Very nicely you analyzed it. We'll take the Q&A. There are some questions both in chat box as well as Q&A section. I'll open the chat box first. Are you able to see the chat box questions?
Yeah, I can see the chat box. So the first question is from Ved Prakash, who asked, in neoadjuvant setting, we should offer chemoradiation or chemotherapy for squamous and adenocarcinoma of the esophagus. So I think we did discuss this during the talk as well, but I do understand that this is a fairly confusing question which we are faced with daily in the clinic. So if you ask me what the evidence says, there is definitely a role for neoadjuvant chemoradiation followed by surgery. There is also definitely a role for neoadjuvant chemotherapy followed by surgery. Now, I do understand that I'm confusing you even further by saying this, but unfortunately, we don't have adequate studies which directly compare neoadjuvant chemotherapy with neoadjuvant chemoradiation, though as I showed in the ongoing studies, there are several ongoing studies which are doing this. If you ask me what my gut feeling is, and I'm not talking from evidence, I'm talking purely based on what I personally believe in, but this is not something that you could probably say in an exam because my opinion really doesn't matter. In squamous esophageal cancers, I think neoadjuvant chemoradiation will be superior to neoadjuvant chemotherapy alone. Whereas for adenocarcinomas, there are enough studies now which seem to indicate that the benefit of neoadjuvant chemoradiation over neoadjuvant chemotherapy or perioperative chemotherapy is likely to be very marginal, if at all. If you were to ask me whether a cross protocol versus a float protocol would be the treatment of choice for adenocarcinomas of the GE junction, my gut feeling is that you would have no benefit with neoadjuvant chemoradiation, and it would come at a slightly higher perioperative morbidity and mortality. So I hope I've answered that question, though there is still no strong data to support one or the other. The next question that we're seeing is, how do we manage intrathoracic anastomotic leaks? This is an excellent question. So earlier we used to insist that we do anastomosis in the neck, primarily because we felt that if it leaks in the neck, it is easier to manage. But what we are seeing more and more as we do, and especially when we are doing a triangulated stapled anastomosis in the neck, is that you necessarily need to leave a longer length of the esophagus, which means that very often the anastomosis sinks down to the mediastinum, even if you have performed the anastomosis in the neck. And as all of you know, if you do an Ivor-Lewis esophagectomy, the anastomosis is anyway always in the neck. So this is an important question. So the consequences of an anastomotic leak are worse if it is in the mediastinum than if it is confined to the neck. But again, having said that, even many of our neck anastomosis, unless you do a very high hand-sewn neck anastomosis, very rarely stays in the neck, and therefore the mediastinum still occurs. But I think one of the biggest improvements that have happened in perioperative management of esophageal surgery has been the advances in interventional radiology. We've had superb interventional radiologists coming in and helping us out with pigtailing collections, ensuring that the leaks don't ultimately translate into mortality. So 2 decades back, or 2.5 decades back, when I trained in esophageal surgery, practically every leak needed to be re-explored and disconnected. And disconnection is an extremely morbid procedure. It requires another procedure to establish continuity, and we lost a lot of our patients because of that. But now almost 90% of our leaks are managed by interventional procedures, and it's very, very rarely that you need to go in and disconnect. But the short answer to your question is that you give a trial of conservative management by keeping the patient NBM, continuing nutritional feeding through NJ feed or Diagnostic, depending on what your preference is. Pigtail everything that is possible to pigtail in the mediastinum. Once you drain the collection, give antibiotics, keep the patient NBM, most of these leaks settle down by themselves, and it's very, very rare that you need to intervene surgically in patients with a leak. So the next question is, what should be the management of supracarinal intrathoracic esophageal squamous cancers? So the recommended margin, the recommended proximal and distal margin in esophageal cancer is 5 centimeters. Now, who made those 5 centimeter margin is just tradition. I don't have strong data to support that, but that is traditionally the margin that we take. So the approach that we take is, if you have 5 centimeter margin of the proximal extent of the growth from the cricopharynx, we would go ahead and offer a multimodality treatment, including surgery. So the approach would be neoadjuvant chemoradiation followed by surgery in these patients. If you don't have a 5 centimeter margin, then we would tend to prefer a definitive chemoradiation as compared to a surgical approach. There are people who take smaller margins proximally and still offer surgery, but that's not an approach that we normally take. But so long as you're able to achieve an R0 resection, regardless of where it is justified. Neoadjuvant chemoradiation followed by surgical assessment or definitive chemoradiation. For adenocarcinomas, I do believe that surgery is essential. Just depending on chemoradiation is not a great approach, because the complete response rates with chemoradiation in adenocarcinomas is not very high. But when it comes to squamous cell cancers, there might be a role. The NCCN even at some point had recommended definitive chemoradiation as an option. Though again, I must say it is completely not evidence-based. Though it is NCCN guidelines, it is not evidence-based. We don't have data currently to support definitive chemoradiation as being superior to neoadjuvant chemoradiation followed by surgery. But as I said earlier, the NEEDS trial that we are now part of is answering exactly this question. In patients with squamous esophageal cancer, will definitive chemoradiation be non-inferior to the cross protocol is the question that we are trying to answer, but currently we do not have the data to support one over the other.
I think next 3-4 questions are in line with the same thing. What is the current status of chemoradiation? You answered. Right. Supracarinal, again you answered. Is there a role of radical intent therapy in oligometastasis of CA esophagus?
Right. So this is the Wild West. I don't think there is any kind of data to support this. But what we typically do is, in patients with synchronous metastatic esophageal cancer, we don't really operate. Again, I wouldn't strongly argue with someone who did, because there is, at least in other solid tumors like lung and renal cell cancers, there is a role. There does seem to be some data favoring radical intent therapy with oligometastatic disease. But with esophageal cancer, I'm not aware of a large series which seem to support that. But with metachronous oligometastatic disease, we have occasionally went in with radical intent. And again, typically this is with nodal disease outside the conventional nodal field. We have treated them radically and we've had some long-term survivals. But again, there is very little data to support that. Do you recommend routine clipping of the chyle duct to prevent chylothorax? So there has actually been a randomized trial to this effect, which has come out of China, and the results are not very strong. So it has not shown an improvement in chylothorax with routine clipping. But what do we routinely do in clinical practice? So at least our approach is that in very early disease where you stayed away from the thoracic duct when you're doing your dissection, we do not routinely prophylactically ligate it. But with advanced tumors where you do a more radical kind of an en bloc kind of a resection where you want to achieve a negative circumferential margin, you do occasionally encounter the chyle duct either deliberately or accidentally as part of the surgery. And our philosophy is that if you dissect the chyle duct, or if you even see the chyle duct, we ligate it intraoperatively rather than leave it alone. There are some data which seem to suggest that your post-operative fluid requirements go up if you ligate the thoracic duct. That has not been our experience, and we've seen very little morbidity with the prophylactic ligation. But again, if you have not dissected or you have not gone in that region, trying to ligate it itself, dissecting it might end up injuring the duct, and that's not something that we would recommend. But if you see the thoracic duct or if you've injured it intraoperatively, we would do the thoracic duct ligation. What's the upper margin in Sievert type 2 tumors? So, if you look at Sievert's own unit in Germany, so we did discuss this issue with some of his junior colleagues. What they clearly said was that though this is theoretically a good division of Sievert's 1, 2, and 3, what practically happens is that there are tumors which traverse all the margins, and it's extremely difficult to actually divide them into 1, 2, and 3. And this is what we see routinely in practice. A 2 of someone who might call it a 2, someone else might call it a 3, or vice versa. So to me, it really doesn't make a big difference into classifying these as Sievert's 1, 2, and 3. What you're really worried about is the actual margins that you're able to achieve. And to me, a 5 centimeter margin proximally and distally is what we should aim at. And typically, a lot of Sievert's type 3 end up having a total gastrectomy with a partial esophagectomy with an esophagovaginal anastomosis. So we would tailor it depending on the actual extent of the disease.
I think, Pramesh, the question they asked is probably, should it be a Ivor-Lewis-like approach, or should it be like a transthoracic plus you take a gastric margin and put it in the neck to prevent a reflex? Because this question keeps coming in exam. To prevent reflex, what would be the right approach? So do you want to do an Ivor-Lewis and keep anastomosis in the right thorax, or treat like esophageal cancers and then you keep anastomosis in the neck? So this question, maybe that's the reason, Fanindra.
Sure. So that's a really good question, and I'm afraid I don't have a very strong data to support one over the other. We do know that reflux is better with intrathoracic anastomosis. So in those patients, especially with a type 2 tumor, whether you do a intrathoracic anastomosis with an Ivor-Lewis or a McEwen's, the oncological outcomes are likely to be similar. And if the reflex is superior with a intrathoracic anastomosis, I wouldn't argue with that approach. It's primarily a question of surgeon preference from an oncological point of view. But I do admit that reflux is a very frequent issue, and for that, an intrathoracic anastomosis is probably superior. Oncologically, it really doesn't make a big difference.
About 2 months back, I also had just posted it. I think there was a phase 2 study comparing treating it like esophagus versus Ivor-Lewis. And they showed a better trend, and overall survival was better if they were treated like esophageal cancer. I'll try to open that paper. It was a phase 2 short RCT about 2 months back published. I'll put it in IASO group also.
Right.
But very short trial, which showed a trend towards overall survival if they were treated like esophageal rather than gastric.
Right. Now, I think there's a strong case for doing that with esophageal cancers, the type 1 cancers. Whereas for type 2 and type 3 definitely not. Type 3 is treated like a gastric cancer. The question is, with type 2, what do you do? I mean, people have done anything from a left thoracoabdominal Garlock kind of an approach, a transhiatal approach, an Ivor-Lewis approach, and even a McEwen's approach. I really don't know the right answer to which of these is superior. When we dismember the anastomosis, or is it not required nowadays? I'm not sure what that means.
I think maybe it's a follow-up question to the leak. You already answered it. In old times, when there was a leak, we almost end up, dismantling the anastomosis, then doing probably a colon pull-up. Nowadays, with intervention, you answered well, that chance is very less. So we may need have to dismantle the anastomosis if there is a leak and try to manage conservatively.
True. That's actually a good point, and I'm glad you brought this because it gets another point. How do you actually manage this leak? So our typical approach is that we'll start conservatively. We'll in patients who are clinically stable, and I think the single most important message I want to leave is your decision on whether you want to take a conservative approach or a more radical re-exploratory approach is based on the clinical progress of the patient. If the patient is clinically stable, continues to remain stable, doesn't become septic, we can go on with the conservative approach of pigtailing collections, antibiotics, keeping the patient NPM, draining whatever collections there are in the neck or the mediastinum. But at the first sign of clinical deterioration with conservative management, if the patient starts going on to a ventilator, starts requiring high doses of inotropic support just to maintain hemodynamic balance, that's the time to go in before you allow the patient to deteriorate much further, because clearly your conservative management is not working and you need to be radical and disconnect the anastomosis, salvage that patient temporarily, and then later on think of a reconnection with using a colon. Any surgical difficulties after chemoradiation versus radiotherapy in mid-esophageal surgery? So with modern radiation techniques, we don't really see much of a problem, but there are two distinct subsets of patients. The ones who are pericarina, the ones who are loco-regionally advanced, the ones with probably very early involvement of the tracheobronchial tree, which are treated with neoadjuvant chemoradiation, we do see sometimes a very intense desmoplastic reaction, and the dissection actually becomes more difficult. But in most other cancers, when you give neoadjuvant chemoradiation, it actually helps the dissection because somehow the planes become better. There is actually a nice dissection that is possible, provided it is not around the carina and the desmoplastic reaction is not there. I would say approximately 20% of cases you see this desmoplastic reaction, and in 80% of cases you have very good planes for dissection. So I have not encountered intraoperatively major problems because of adding chemoradiation. Is there any difference in leak rates among Hansoon or stapled anastomosis in the neck? So typically what we do, so we've done over 1,000 stapled anastomosis over the last 7 years or so, and we have an equivalent over 1,000 Hansoon anastomosis in the previous 10 years. What we've seen is that leak rates really don't change much. It is disappointingly, though we felt initially that with the stapled anastomosis it would be lower, leak rates have remained remarkably same. What has been a dramatic difference, and again I must qualify the stapled anastomosis as a linear, triangulated linear stapled anastomosis, not a circular anastomosis. The anastomotic stricture rates have completely disappeared. We used to have to dilate about anywhere from 5 to 10% of our patients after a Hansoon anastomosis earlier on in the between 2000 and 2010. I don't remember the last patient we've had to dilate in the last 7 or 8 years, because when you, and we see this when we investigate patients who are not behaving well in the immediate postoperative period, we have a very low threshold to do an upper GI endoscopy to rule out gastric tube necrosis. And your endoscope just walks into the stomach tube. The anastomosis is so voluminous that strictures have completely disappeared in with a stapled anastomosis. But leak rates, I don't think are making, there's a big difference.
Yeah, absolutely. I'll add a line. It's like a diamond anastomosis. I totally agree, but it's very important for young students to know that if you are overzealous and use half of the 100 stapler, the purpose of giving the anastomosis in the neck refutes, because the lower tip would then drop down below the clavicle and thoracic inlet. And when it leaks, instead of it coming through the neck, it may still be an intrathoracic leak. So it's very important when you do stapler to understand not to be overzealous. Don't fire too low, and the lower tip of the anastomosis of the diamond doesn't drop down below the clavicle. And when they leak, they still come down, and you still think, I actually did esophagectomy, stomach pull-up, left neck anastomosis. Why is it leaking in the right thorax? Second is, you have fired one stapler for a stomach tube. The second linear cutter might be very close to that, and you have a small rim of tissue which may necrose. So there are a lot of quality points in stapler which big centers like Pramesh who has done has mastered it. So students should be aware of this.
So actually, there are some nice videos on YouTube if you want, looking at describing this technique. So what Dr. Somshekhar said is absolutely right. Being overzealous and using the vertical stapler too long can actually make the tip of that very ischemic and can frequently result in necrosis. When would you consider? Yeah, that's done. How often do you see gastric conduit necrosis? Not too often, fortunately, because it's really one of the most dreaded complications after an esophageectomy. Morbidity and mortality rates are extremely high, so you need to be extremely careful intraoperatively that you don't devascularize the stomach. The gastric arcade is treated like a newborn baby, whether it is done in open or in a minimal invasive approach, and you ensure that you actually don't handle the gastric arcade too much along the greater curve. And with adequate precautions, this rate is extremely low, less than 1% in most high volume centers.
And now most of the centers, when they do robotic or lab, they just throw an ICG at the end of it. And they quantify the ICG perfusion at different levels of the stomach in the fundus, body, and then distal part of the greater curvature. And where you can keep the anastomosis. So after that, it's practically very close to 0%.
Right. So what should be the ideal width of the conduit? Again, there are no strong recommendations for this. It's anywhere from 4 to 5 centimeters is what is recommended. So you have advantages and disadvantages with both. So if you keep it too wide, the advantage is that it's a more vascular structure. The stomach stays more vascular. But at the same time, the passage of food through the gastric tube becomes slower because it becomes more a reservoir than an esophageal tube, a neoesophageal tube. If you keep it too narrow, what happens is it increases the chances of ischemia and therefore gastric necrosis. So typically anywhere from 3.5 to 5 centimeters is what we would, width is what we would recommend. And this is something that can be easily done intraoperatively.
Superb. In Q&A, there are a lot of questions, but with the want of time, I'll just pick 2 of them. There is one more box, chat box, which is Q&A box. There are about 6 to 8 questions, but I'll just pick 2 of them. Maybe we have to end because everything has to come to an end, all good things. If a patient post concomitant chemoradiation achieves clinical radiological complete response, as of today, is there any role of observation like it is coming in organ preservation protocol in other organs?
Right. So with the evidence that we have today, if you have gone ahead with a neoadjuvant protocol, that is 41.4 Gray, what you see in a cross protocol, the current recommendation would be to go ahead and resect these patients, because we still are not 100% sure that a clinical radiological, even including biopsies and PETs, are adequate to completely rule out a residual disease, and we don't have the data to support just observation. This is exactly the question that the Sano trial is trying to answer, which is being led out of Netherlands by Professor Van Lanschot, which is answering the question whether after a complete response after neoadjuvant chemoradiation with very intensive surveillance, with 3, as I said during my talk, 3 monthly upper GI endoscopies, regular PET scans. Endoscopy is always associated with multi-quadrant biopsies, and if all of them come negative, there might be a role, but we still don't have the answer. The randomized trial is being conducted in Netherlands as we speak.
Thank you. Dr. Radha is finally asking, sir, in exam, if they ask us, what is the current extent of lymphadenectomy in esophageal surgery? Is it 2-field, 3-field? What should we answer in exam?
Yeah, based on the current data, if you're likely to go for your exams before our trial gets published, I would say that the standard is a standard 2-field lymphadenectomy. We currently don't have strong data to support 3-field lymphadenectomy, and I must also say that 3-field lymphadenectomy does come at a cost. The incidence of recurrent laryngeal nerve palsy is much higher, even in the best of centers with a 3-field lymphadenectomy, because especially with the supracarinal part of the left recurrent dissection, it's a long length of the left recurrent nerve, which when you dissect radically in that region, your chances of temporary paresis at least is pretty high, and the chances of aspiration postoperative is a real problem. So I wouldn't take a 3-field lymphadenectomy lightly. It has to be done in experienced centers by experienced surgeons. But as it stands now, there is no strong data to support a 3-field lymphadenectomy. But this is in patients who on radiology do not have supracarinal nodes. If you have radiologically positive nodes, either on PET-CT or on CCT above the carina, leaving behind those nodes really doesn't make sense. You should do a 3-field lymphadenectomy. But in patients who don't have radiologically positive nodes in the supracarinal region, the current recommendation would be to do a 2-field lymphadenectomy.
Thank you very much, Pramesh. I have to let you go, but I'll ask 2 basic silly questions which every student is asking me to ask you. What should be the current role of pyloromyotomy or pyloroplasty after esophageal? Number 1. Second, role of feeding jejunostomy. What should they answer as of these 2 questions is concerned?
Right. So for the first question, there are actually a few randomized trials and a meta-analysis. It's fairly old. Even the meta-analysis happened in 2002 or 2001, which means that the trials were done prior to that. And to the best of my knowledge, there are no further trials that have been done after 2001 or 2. So this is old knowledge that we have, which showed that outcomes were similar whether you did a pyloric drainage procedure or not. But if you go into the details of that meta-analysis, there's one area where doing some kind of a pyloric drainage seems to help, and that is in the incidence of fatal aspiration. The incidence of fatal aspiration was substantially higher if you did not do a pyloric drainage procedure as compared to a pyloro with no drainage. Now, what we do is a kind of a compromise. We don't do a full pyloromyotomy or a surgical pyloromyotomy or a pyloroplasty, what we do is when we take the stomach tube out to create the stomach tube, we open the stomach tube at one point, we put in a dilator, even a sponge holder, which we use as a dilator, take it across to the pylorus, and we dilate the pylorus internally very widely. Now, I don't know whether this helps or doesn't help, whether it is reducing aspiration, whether it's reducing stasis, but it's a small, it just takes 2 minutes to do intraoperatively, and we've not had a problem with that. So again, no strong data to support any form of pyloric drainage over no drainage. But practically speaking, this is something that we do. The second question was, I forget, so?
Feeding jejunostomy requires.
Yeah. So having some kind of a nutritional support, either by way of a nasojejunal or a feeding jejunostomy, is something that I would recommend, because in the best of hands, some patients leak, and you don't want to be left without any way of feeding before you are able to salvage these patients. But having said that, this is probably advice 10 years old. But having said that, currently, with leak rates going down, with most leaks being managed with intervention, again, endoscopically putting in a nasojejunal tube, endoscopically or with IR guidance, putting a nasojejunal tube has become a very straightforward procedure. So if someone doesn't want to add an additional procedure with a feeding jejunostomy, I would not argue with that person. But what we do again is something very practical. We don't, with the minimal invasive surgeries, we don't put any tube intraoperatively, but we put in a nasojejunal on the first postoperative day under IR guidance. So we are still able to feed the patient substantially till the patient goes on to full orals. We are very, very aggressive with an ERAS protocol after surgery. We mobilize patients either on the evening of surgery or the next day after surgery. We start them on sips of water the first day after surgery and slowly build up the liquid intake. By the time the patients are on the 7th or 8th postoperative day, they're practically onto a normal full diet. But if you are not able to implement these ERAS protocols, then having a nasojejunal tube to tide over the week after surgery is very useful. But we've gone completely away from feeding jejunostomies, because if you do enough feeding jejunostomies, you realize that it's not such a harmless procedure. If you do, so we've done close to 1,500 feeding jejunostomies in the earlier part of our esophageal surgery experience, and we realized that feeding jejunostomy related complications are 2 to 3%. Either you might have a twisting of the loop or some kind of a leak from the jejunostomy, and it's not something, for something which is supposed to be a supportive procedure, having that lead to a morbidity is something which is tragic, and therefore we moved away to a nasojejunal tube, which patients tolerate fairly well.
And the role of leak test before starting orally in esophageal anastomosis case?
So we've completely stopped. I don't remember doing a Condray solo for the last 15 years at all, because leaks present clinically. If you have a good clinical examination, these are subtle signs that you're looking at. A leak may not always present with a bulge in the neck or fever. You need to look for subtle signs like even a low-grade temperature. Arrhythmias are sometimes very frequently seen with mediastinal leaks. You might have patients getting breathless because of mediastinitis, because of a leak. And having a low threshold to investigate patients with a leak is what is required. Very often when we used to do Condray 15 years back, we used to come up with very small outpouchings in the neck, and which are clinically inconsequential leaks. And these are not things that you need to bother about. So we've completely stopped doing any kind of contrast study after to rule out leaks in the postoperative period.
Super, Pramesh. Thank you very much. It's been so lovely. It's like an encyclopedia. Students are pouring questions both in Q&A. I know all good things has to come and end. And I always tell our DNB students, the purpose of the teacher is just to stimulate you. We can't spoon feed you. This is not school. We now stimulated with all the ideas you gave. They have to go and walk the path. And we just show direction, they have to walk it. And a fantastic presentation. I'm so happy I waited for you. It fulfilled my dream. And students are overwhelming me thanking you. And Navneet Singh also is posting all congratulatory message to you. Thank you, lovely. More than your talk alone, the precious time you kept for the students. You know, students are at the lower state of pyramid. You are at the top. This is the only platform where we can make them meet you, because it's not easy to get. And I'm so happy, and I thank DNB, DNB, and also Navneet Singh to provide this platform. And great, heartful thanks. Grateful to you for accepting our invitation.
Thank you very much, Som, for pushing me and encouraging me to be part of this. I've completely enjoyed preparing for this talk as well as the interaction. I didn't, honestly, I didn't expect the kind of interaction that has come out on the chat and the Q&A. So thank you for the opportunity to be part of this.
Thank you very much. Thank you. Over to Navneet Singh ji.
Thank you very much, Professor C.S. Pramesh, for the presentation, and thank you very much, Professor Dr. Somashekar, for joining us. And thank you, trainees and faculty members, for joining us.
Thank you.
Thank you very much. Thank you.